first part of the abdominal examination consists of inspection or examination for extra-abdominal signs of abdominal disease. These can be characterized under the following heading. On the CNS, one will do a mental status exam. Under the hands, one will look for clubbing, koilonychia, leukonychia. The palm of the hands, we look for palmar erythema, Dupuytren's contracture, palmar crease pigmentation, and also the evidence of flapping tremor. Okay, under the arms, one will look for muscle wasting, bruising or scratch marks indicative of pruritus. Under the face and eyes, one will look for conjunctival pallor, jaundice and icterus, jaundice of the skin around the eyes and icterus of the sclera, evidence of Keissner-Flaschner rings in the cornea, xanthelasma around the eye, dehydration in the form of sunken eyes, and parotid enlargement, which will be manifest in front of the tragus. Under the mouth, and this includes tongue, lips, and gums. Feta hepaticus will be appreciated in terms of the smell. Examine the tongue for atrophic glossitis or foreign of the tongue. Also evidence of candidiasis, ulceration, and pigmentation of the mucosa. Look for evidence of leukoplakia. At the angle of the mouth, look for angular stomatitis. The gums should be examined for gingivitis, bleeding gums, or gum hypertrophy. Under the neck, one will check for supraclavicular lymphadenopathy in the supraclavicular fossa. Under the chest, one will examine evidence loss of hair and reduced skin turgor, which is loss of elasticity. Under the genitalia, we will not demonstrate in the lab, but one will look for testicular atrophy. Under the lower limbs, one will check for pitting edema, and you examine it over the anterior shin, the dorsum of the foot, and behind the medial malleolus. In the cardiovascular system, pulse and blood pressure is checked, and this will be done during vital signs. In the examination of the abdomen proper, it is important that the patient is in the right position and be draped correctly. Abdominal examination is done with the patient in the supine position. The head must not be elevated. The abdomen must be exposed from the clavicle down to the suprapubic area. Examination of the abdomen starts with inspection, followed by auscultation, then palpation, and percussion being the last aspect of the physical examination. On the inspection, the first part of inspection is done with the examiner standing at the foot of the bed and observing for the following: the contour of the abdomen, which involves the size and shape, must be looked at. Normal shape is a flat abdomen. It could also be scaphoid. Look for evidence of protuberance or distension, will be manifested by bulging in the abdominal wall. Look for symmetry of movement of the anterior abdominal musculature. Look for any evidence of exaggerated respiratory movements. The normal respiration, the abdominal wall moves out during inspiration and in during expiration. Look for evidence of paradoxical abdominal movement, which is opposite to what was mentioned before. And look for any evidence of absent respiratory movement, that is movement with respiration, which may indicate peritonitis. Is done with the doctor standing on the right side of the patient. First, examine for evidence of skin changes, and these include changes in color. Look for evidence of stria or stretch marks. Look for evidence of ecchymosis and bruising. Look for scars which may indicate previous abdominal operation. Look for engorged veins, spider angiometer, or caput medusa. Examine for evidence of masses, obvious mass which will be manifested in bulging or protuberance of portions of the abdominal wall. Look for evidence of visible peristalsis or pulsation, which should be done by viewing the abdominal wall from in a tangential position. Look at the navel. That means look for the evidence of the navel being inverted or everted. Examine around the navel for evidence of herniation. Examine for the presence of any mass which will appear when the patient sits up without support. Look for bulging around the umbilicus, bulging in the groin area, indicative of herniation, umbilical or inguinal hernia. Please note that auscultation of the abdomen follows inspection, unlike the examination of the respiratory and cardiovascular system, where auscultation is the last skill practiced. Under auscultation, we will listen for bowel sounds. The presence of normal bowel sounds. One normally listen in the right lower quadrant, because the abdomen being an open cavity, it will be appreciated the same all about. The normal bowel sound is intermittent, low pitch, chuckling, and at intervals of 5 to 34 per minute. If no bowel sounds is appreciated, one must listen for a couple minutes to say that there is no bowel sound. One can also appreciate the presence of high-pitched tinkling sounds, which may indicate obstruction. The next one should listen for bruit, and bruit can be appreciated in the epigastrium for the aorta. It can be appreciated over the renal vessels, indicating renal artery stenosis. One can also listen over the iliac for bruit in that area. After bruit, one should listen for friction rub. Please note, friction rub is over the hepatic area and splenic area. In both areas, one listen to the lower lateral costal margin. For the liver, one listen over the mid-clavicular line, and for the spleen, mid-axillary line. After friction rub, one listen for venous hum, which is in the right lower quadrant in the subcostal area, just anterior to the mid-clavicular line. The palpation is done to appreciate the presence of tenderness or to appreciate any abnormal masses or organomegaly. Please note that before palpating for tenderness, one should ask the patient if they have pain in any area, and that area will be left for the last. In the absence of pain, one will start superficial palpation in the right lower quadrant, then proceed to the right upper quadrant, then the left upper quadrant, followed by the left lower quadrant, and then periumbilical. One should perform these things in order so that one will not miss any particular area. Deep palpation is done in the same manner but this time more pressure is applied to the abdominal wall. It can be done one-handed, or it can be done two-handed, with one hand on the top hand pressing the bottom hand. After testing for tenderness, one then checked for organomegaly. We will first palpate the liver. Remember, the liver enlarges down towards the right lower quadrant, and therefore palpation should start in the right lower quadrant. Palpate with the right hand resting on the abdomen, lateral to the rectus muscle, with the fingers pointing superiorly in line with the mid-clavicular line for the right lower of the liver. Ask the patient to take deep breaths in and out with the mouth open, depressing the fingers into the abdomen on expiration. As the liver moves up and down, eventually the lower edge of the liver may be felt hitting against the fingertips. This may not occur until the subcostal area is reached. One may also place the left hand parallel to and supporting the right 11 and 12 ribs and pressing it anteriorly and while palpating, and this may make the liver more readily palpable. We will now demonstrate palpating the left lobe of the liver. The first technique described was for the right lobe, starting at the umbilicus with the fingers again pointing superiorly. Palpate the abdomen while the patient takes deep breath in and out. Palpate from the umbilicus to the xiphoid. Normally, the left lobe of the liver is not felt. We will now demonstrate palpation of the spleen. Remember, the spleen enlarges towards the right lower quadrant, so one has to start from the right lower quadrant. The normal spleen is not palpable. With the patient supine, palpation of the spleen starts in the right lower quadrant. The right hand and fingers are placed on the abdomen with the fingers pointed towards the left shoulder. The left hand is placed behind and supporting the left 9th, 10th, and 11th ribs parallel to the 10th rib. The left hand pushes anteriorly, thus bringing the spleen closer to the palpating hand. Move the palpating hand towards the left subcostal area with the patient taking deep breaths in and out. If the spleen is palpable, measure the distance between the tip and the left costal margin. Alternatively, the patient can be placed in the right lateral decubitus position with both hips and knees flexed. Palpate in the left subcostal area with the right hand and the left hand in a similar position to that mentioned before. Remember, this is used only in the spleen, only the spleen was not palpated in the previous position. Palpate the right kidney, stand on the patient's right side, place the left hand over the right flank between the costal margin and the iliac crest. Palpation of the kidney. To palpate the right kidney, stand on the patient's right side, place the left hand over the right costal vertebral area with the hand line between the costal margin and the iliac crest. The examiner's right hand is placed just below the patient's right costal margin, lateral and parallel to the rectus abdominis. While lifting with the left hand, ask the patient to take a deep breath while pressing deeply in the right upper quadrant with the right hand. At the peak of inspiration, the examiner may be able to capture the lower pole between the two hands. Repeat for the left kidney by standing on the left side of the patient. Place the right hand under the left flank in the area of the costovertebral angle, lifting with that hand. Press down in the left upper quadrant with the left hand positioned parallel and lateral to the rectus abdominis muscle. The left kidney is not normally felt. We will now demonstrate palpation of the aorta or aortic pulsation to determine the presence of aortic aneurysm. Press firmly in the epigastrium and determine the presence of the aortic pulsation. The normal aortic pulsation is to the left of the midline. The width of the pulsation can be determined by pressing down deeply on both sides of the pulsation with a hand on each side and then measuring the width. The width should be less than 2.5 centimeters. A diameter of 3 centimeters or more is considered an aortic aneurysm. For general percussion of the abdomen, start percussing in the right lower quadrant with the right hand resting on the abdominal wall. Percuss up to the right upper quadrant, then to the left upper quadrant, then percuss the left lower quadrant, and end in the periumbilical area. Next, we will percuss the right lobe of the liver, and we percuss along the mid-clavicular line. For the left lobe, we'll percuss along the mid-sternal line. Start in an area of tympani below the umbilicus and percuss upwards until an area of dullness is reached. Note that point. Starting from above, percuss, starting from above at the nipple line, percuss downwards until a dull area is reached. Make note of that point and measure the distance between both points. This will be the right lobe of the liver span. Okay, to percuss the left lobe, start from the umbilicus along and percuss along the mid-sternal line towards the xiphoid. Measure the distance between from the dull point to the xiphoid, and this will be the left liver span. Remember, the measurement of the liver span is 6 to 12 centimeters for the right lobe and 4 to 8 centimeters for the left lobe. Generally, percussion of the spleen is done in the absence of palpable organomegaly or splenomegaly. Place the middle finger of the left hand in the 10th interspace in line with the anterior axillary line. Percuss, go ahead. Percuss, this should be tympanic. Ask the patient to take a deep breath in while continuing to percuss. This should remain tympanic during this time. If the sound changed from tympany to dullness, this indicates splenomegaly. Okay. The above percussion technique can also be done with the patient in the right lateral decubitus position. Next, one should percuss in the midline and the suprapubic area to determine the presence of dullness. Start from the umbilicus and percuss down. Dullness in this area in the male usually indicate a distended bladder. In the female, it could also indicate an enlarged uterus. Remember, a rectal examination should always accompany an abdominal examination, but this will not be demonstrated in the lab. And remember, it's done with a gloved hand using the index finger, and the patient may be in the lateral, mid-lateral position, or may be in the sort of reverse lithotomy position. That means they're kneeling down. Under special tests for abdominal examination, we will do the following. We will test for signs of peritonitis, test for fluid in the abdomen, the test for acute appendicitis, the test for acute cholecystitis, and the test for pyelonephritis. For peritonitis, the following features will be demonstrated. direct tenderness, guarding, and rebound tenderness with rigidity. For direct tenderness, place the right hand flat on the abdominal wall with the fingers together and side by side. Exert gentle, steady downward pressure with the pads of the fingers over the area being examined. Observe the patient's face for grimacing. This is an expression of pain. Remember, tenderness is, you check for tenderness in all quadrants of the abdomen using the same technique. For guarding, with the patient again lying supine, place the right hand flat on the abdomen, fingers together and side by side. Palpate the appropriate areas with the pads of the finger as outlined above, this time exerting firmer pressure. If there is guarding, the patient will resist depression of the abdominal wall with your finger. Rigidity is done in the same manner. Rigidity, remember, is involuntary, and in most circumstances, one cannot depress the abdominal wall to any great extent. For rebound tenderness, again with the patient lying supine, place the right hand, fingers by the side and together flat on the abdomen. Using the pads of the finger, exert steady, gentle, deep pressure on the abdominal wall for 5 to 10 seconds. Normally, if there is an acute abdomen, the patient will appreciate pain. Release the pressure by suddenly lifting the hand off the abdomen. In the presence of rebound, the patient will experience an increased intensity of pain when compared to the pain due to direct pressure. An alternative method of eliciting rebound tenderness will be rocking the bed, or just general percussion over the abdomen, or what they call the pinch test. Lift with the thumb and index finger a flap of abdominal skin and then release it. If pain is perceived, rebound tenderness is present. These latter three methods are much kinder to the patient as a method of determining rebound tenderness. Tests for fluid in the abdomen. There are 3 tests for fluid in the abdomen. One is observe for bulging at the flank, because with the patient supine, any fluid will accumulate in the flank. Now examine for the presence of fluid wave. Have the patient lie in the supine position. Have the patient on assistant indent the anterior abdominal wall in the midline around the navel with the ulnar border of the hand. The examiner places his left hand against the right flank of the patient and taps the other flank with his right hand. If sufficient fluid is present, a fluid wave will be perceived by the left hand. For shifting dullness, the patient is again in the supine position. Percuss the abdomen from the midline to the flanks until dullness is appreciated. Make a note of that point. Turn the patient in the left lateral position. Percuss from the point of dullness towards the umbilicus. One will note that the dullness moves from the flank towards the umbilicus if there is the presence of fluid in the abdomen. The extra fluid coming from the right side to the left side on turning on the left side. The procedure can also be done turning the patient on the right side and following the same technique of percussion. One will test for signs of peritonitis and we will perform the Rovsing sign, the source sign, and the obturator sign. Signs of peritonitis, we will test for direct tenderness, rebound tenderness, and guarding in the right lower quadrant. In the Rovsing sign, the examiner applies gentle, steady, deep pressure with the pads of the fingers of the right hand over the left lower quadrant of the patient. The patient who feels pain in the right lower quadrant during this maneuver has a positive Rovsing sign. In the source sign, the patient is instructed to lift his right lower leg straight, that means extended at the knee and flexed at the elbow. While the patient is lifting the leg, the examiner applies counter pressure over the area of the thigh. Pain in the right lower quadrant during this procedure is a positive source test. Remember, the source test is positive when the appendix is located in a retroperitoneal, retrocecal position. With the obturator sign, instruct the patient to bend his knee, then flex the thigh on the right hip, directing the right knee towards his or her left shoulder. During this procedure, the examiner applies counter pressure to prevent the internal rotation at the hip. Pain in the right lower quadrant during this maneuver indicates a positive obturator sign. Remember, the final test for acute appendicitis is a digital rectal exam. There are two tests for acute cholecystitis. There's the Murphy sign and the Bose sign. With the Murphy sign, place the right hand on the abdominal wall in the right upper quadrant. The fingers should be together side by side and pointing towards the right costal margin. Palpating the line of the mid-clavicular point. Ask the patient to take deep breaths in and out, pressing down with the fingers and then releasing the pressure. Move the hands superiorly while palpating in small increments towards the right costal margin. A patient with acute cholecystitis, on reaching the area of the gallbladder, inspiration will suddenly be cut short due to the presence of pain. In demonstrating the Bose sign, the patient should be sitting up in the bed, lightly scratch the skin below the inferior angle of the right scapula. A positive sign is an uncomfortable sensation perceived by scratching.
Do you feel anything?
While the patient is in the same position, we will test for pyelonephritis. It is known as fist percussion. Place your left hand over the right costovertebral angle. Make a fist with your right hand and strike your left hand with a brisk but gentle thumb. A test is positive if pain is elicited with this maneuver. Good. Repeat on the other side.